My name is Paul Gagne. I'm a vascular surgeon with Southern Connecticut Vascular Center. And what I wanted to do tonight is just kind of give you a quick review of some of the technical changes that have evolved over the last almost 10 years now, since we first started putting endografts in 2007, and kind of show you that where we've been, where we're going, and where I think we're going. This is a slide that shows the just as one criteria, the impact of delivery system profile. So we put a hole in the artery in the groin, and we slide a delivery system, a catheter system, up through the femoral and iliac arteries into the aorta, and then we release the graft into the normal aorta on either side of the aneurysm in the abdomen, and then that basically relines the aorta. And you can see here that when you look at the right, the size of the device here, and this is going back to where we started around 2000, 2001, the number of patients who could be treated with these large 25 French devices was much less than where we are. We now have 14 French devices, and based on the anatomy of these patients' access vessels, we're talking the common femoral and iliac arteries, we can now deliver these devices to a much greater number of patients. And so this mirrors what we're seeing clinically, is that as the technology gets better, we're able to treat more and more patients. When we started this in 2001, we estimated that about half the patients would be endograft options, and the other half would require open repairs. And you can see now, this is where we are. About 90 to 95% of patients probably can have an endograft technically. Now, you've heard some of this language tonight. We've talked about aortic size, but it's more than just the size of the aneurysm. We want to look at the proximal neck. Here's the renal arteries in this 3D CTA. Here's the neck, which is the normal artery. It can be short. It can be adequate. The first devices wanted a 15 millimeter neck. That's changed, 15 millimeters of normal aorta neck. And then the angle of the neck is important. That's the axis when you go from here out to here. And I'll show you some examples. Sometimes there's not such a straight line, and that puts strains on the device. Then we have to look at the distal landing zone. We have to seal it in some normal artery here, which means we have to have normal artery. You can't have a large aneurysm. If you do, you have to make adjustments for that. Also, if you have a small artery and you can't get the device up through the small artery, you can't fix the aneurysm with an endograft. So those are some of the specific challenges that have been taken on and confronted, and in fact addressed by a lot of physicians with techniques, but also with industry with new innovations. These are some of the challenges we handle. This is a nice straight neck, that normal aorta that we can plant the proximal part of the graft at. But if you have an angle like this, or a tapered neck, or a reverse tapered neck, or a short neck, you have problems, because you may have problems sizing the graft, you may have problems getting that graft to seal. So these are the endoleaks you already, These are the endoleaks you already heard about. That neck configuration is important regarding type 1 endoleaks. The size and configuration of the iliac vessels is important for both the seal and to keep the limbs of that graft from kinking, but also for delivery purposes. So this is an example of a very tortuous external and common iliac arteries. You can see this almost does a complete loop here, and you can see the wire going up through that artery as you're trying to deliver a straight, heavy-duty, and stiff device. Now, this is what happens when you try to force a device into a small artery. When you pull it out, sometimes you get what we call an artery on a stick, which is the artery gets avulsed out of the patient. It's not a good day, because now you have a frank rupture inside the patient's pelvis that you have to fix. And traditionally, small elderly females with stiff, diseased small vessels, especially small external iliac arteries, are a problem in that group. Now, this is a nice straightforward aneurysm, right? If you could only have the ones that they draw. Okay, you've got a fairly straight artery, not much of a neck here, but we'll ignore that. You've got nice straight vessels here, they're nice and big, and you can put a graft in there in most anybody, assuming there was a little more neck here. Now, Gagne was one of the first to market with a graft, and for reasons unrelated to the quality of their graft, they're no longer making grafts. Cook and Gore probably have two of the longest standing grafts on the market. They're workhorses. They've proven to be very reliable over time, but they have some limitations from a technical point of view. They were superb first or maybe second generation grafts, But the problems that they couldn't address have now been addressed by some of the grafts that have followed on, such as Endologic, which has now been out for a number of years, Medtronic's on their third version of graft, and their most recent addition to the armamentarium has a lot of possibilities, which I'll go over. And then we now have two most recent additions. The Trivascular has come out with a graft, as had Lombard Medical has come out with an Aorfix, and we'll go over some of the details of this. Again, not that I expect you to be experts, but I think it's important to understand when you send somebody for a referral for evaluation, when they say this is not such an easy endograft or this is an easy endograft, you understand what we're thinking about. So this is a Zenith graft by Cook. Again, something that's been around now for 10 years. It's very durable, reliable, and relatively versatile for this generation of grafts. You can see you have a nice neck here, relatively straight vessels, and this seals very nicely. And this can deal with a large number of aneurysms that we take care of. But because necessity is the mother of invention, there are other alternatives, as I've alluded to, because there are other considerations. We have to think of the morphology of the aneurysm, and also, do they have concomitant PAD? Do they have heavily diseased iliac vessels? And more importantly, do they have lower extremity infrainguinal disease? Are you going to fix their aneurysm and then want to come back in a year or two to treat their SFA stenosis or their popliteal disease because they're having lower extremity symptoms? And so this is a standard bland fusiform aneurysm, very typical. This is a saccular aneurysm. You can see that the size of this aorta is relatively normal, but you've got this blowout here, probably from a penetrating ulcer, for example. So what you may want to do is this graft, the endologic graft for that condition with a blowout. You're going to see here, this is a fusiform aneurysm, but look how this graft comes out. You see it sits on the bifurcation here, which we'll see in a second. This preserves the ability to go up from one leg across to the other to treat their PAD down the road, so you don't lose that option the way you do with some of the other grafts. And then it kind of billows out and it fills the artery. So it fills the normal artery, but it also plugs the hole for that saccular aneurysm. And this is a good option for those type of clinical problems. And I'm going to keep moving forward. This graft is not fully deployed, but there's an extension that goes up and seals it up here, but in the interest of time. Now, vascular access. John alluded to this a few minutes ago. The traditional approach for access is that we go ahead and we make a cut down and we pass the graft up through these arteries. But you can imagine, for example, in an obese patient, that groin incision, as highlighted here, can be more morbidity than actually fixing the aneurysm. And so what we used to do is groin incisions in both groins. We would pass the graft up under direct visualization into the artery, repair the artery, close the groin incisions. Now, compared to a laparotomy, that's a great advance. But if you can do it percutaneously, that's even better. And so Endologic went and got the FDA approval for percutaneous endovascular aneurysm repairs. And so what we do is we take a ProGlide device, which is a closure device from Abbott, and we put it in the artery. Then we pass the sheaths and the delivery system for the endograft up through the ProGlide device. At the end of the procedure, we fix the aneurysm. We pull out the delivery system for the graft. We pull out the wires. We close the sutures up in the artery percutaneously, and then we have a small puncture in the groin, and the patient's aneurysm has been fixed. This is where we're going to start seeing patients potentially going home the same day. It's not happening so much yet, but it's not hard to imagine that if you take somebody who's relatively healthy with a fairly straightforward aneurysm, and they happen, and you can fix them percutaneously, it's not going to be long before the insurance companies start saying, well, why aren't you sending them home? Now, the PVAR trial was the trial that allowed the FDA to approve percutaneous AAA repair. 50 patients went to surgical randomization, surgical arm, 50 to the percutaneous arm. They showed that the PVAR, the percutaneous complications were low, and the technical success of percutaneous closure was 94%, quite high. And if they do have problems, you usually recognize it right there in the OR, so you don't go out to the OR, go out to the recovery room and then bring them back. You recognize it right there, you do a cut down and you fix the artery. In this case, you're only cutting down on 6% of the patients rather than on 100%. And what it really does is it really shortens procedure time, anesthesia time, and post-op pain. Now, endograft delivery system, there are a lot of differences in the delivery system, and this has been an evolution over time. The size of the system and also the flexibility of the system is quite important. The question is, are they as good as the gold standards? Do they deliver a good graft? Well, the answer is they're getting there. This is the Endurance system. This was a system that came out a couple years ago and has been doing quite well. Their graft is not that much different in many respects than others that are on the market as far as the general design. But some of the attributes of this graft are it allows you to treat at that short proximal neck. So if you remember, I initially said a 15-millimeter neck was the standard IFU, the instructions for use for aortic endograft. Well, now we have patients with short aortic necks that we can treat that we couldn't really treat as well before. It can also deal with a very angulated neck. So if you have a tough angle just below the renal arteries, this graft will take that angle and will remain in place and give you a durable repair. And finally, it's a fairly flexible system, and it takes these small tortuous access arteries very well. So this was a definite move in the right direction. And these are some of the examples of what it can do. You can see these very tortuous iliac arteries. You can get a graft up and through those. This graft takes those angles well. You can see the angulation of the neck. Okay, this would be 0. This is almost 60 to 70 degrees. And you can see the graft in here is nicely in place with a good seal. So that's functioning. And then you can see this very tortuous neck. It's almost like an S shape. Okay, the graft is laying in here and gets a good seal and a good outcome. And then finally, a short neck. Okay, not much room here. In the past, sometimes we have to worry about getting a seal there and a type 1 endoleak. And this graft is designed to be able to handle that. So changes and improvement in technology are allowing us to treat more patients, more difficult anatomy, to the point where that difficult anatomy is not as difficult as it used to be. Now, let me just show you an example of some severe proximal neck angulation. This is the AorFix graft from Lombard Medical. It's out quite recently, and it's just been approved by the FDA for neck angulation up to 90%. So I showed you the Endurant graft that's talking about an angulation of 60%. We thought that was a great step forward. Now, this new graft is suggesting they can handle a angulation of 90% with decreased type 1 endoleaks and long-term aortic exclusion. This is a relatively new graft, and I would say we don't have a lot of experience with it yet, but the promise from these trials that are allowed for this approval certainly suggests we'll be able to continue to expand the patients that we can treat with an endograft. And this is what that looks like in place. I'm not sure this is quite a 90% angle, but a fairly angulated neck, and the graft is in place here. The orange graft, you can see it inside. Now, what's really interesting is the miniaturization, I love this, the miniaturization of minimally invasive EVAR, okay? And what's happening is we talked about the size of the access vessels. So you can see these small tortuous vessels, diffusely diseased vessels, okay? This is what we don't want to happen, artery on a stick, because we tried to put a big device up into a small diseased vessel. That's a free rupture into the pelvis because of that. So what you've seen happen is devices have gone from over 20 French out here down to 14 French with the new Ovation Prime graft from Trivascular. And so now we have another fairly new graft that allows us to deal with access arteries that are in the vicinity of 4 to 5 millimeters. An access vessel that in the past with prior devices would be a real challenge potentially. And so this is this new Trivascular graft. Again, it's 3 pieces, the main body and 2 limbs that get overlapped and fitted in here. The difference is there's not much metal up here that allows them to make a smaller graft and put it into a smaller delivery system. It seals not by a stent up here, but these rings are inflated, and so it forms like 2 gaskets within the normal aorta to stop the flow around the graft and direct the flow into the graft. Now, pararenal aneurysms used to be an absolute contraindication because there was no place for the graft, there was no normal aorta for the graft to anchor at the level of the renal arteries. So what do? Well, Cook came out with their Zenith fenestrated graft. This is a graft which allows you to take advantage that oftentimes in an aneurysmal aorta, the aorta at the level of the renal arteries is oftentimes normal. Well, the problem is if you put a graft there, how do you not exclude the renal arteries and cause renal artery ischemia? What this graft does is you can see a cutout here for the superior mesenteric artery, and then on either side there's a hole in the side of the graft. And you put a stent out into the renal arteries to maintain flow into the renal arteries, and it also serves to anchor the graft in place. And so this is a graft that came out a little over a year ago with limited release. But this is what it looks like in a model. You can see the body of the graft. You can see the wires and stents going out into the renal arteries. And this is what it looks like deployed. You can see the stents out here. This is the graft. You've got a seal zone over here, and this is the other renal artery going out to the left. This is a fenestrated graft. They're also looking at fenestrated grafts and concepts for the aortic arch. Now, a proximal type 1 endoleak. One of the problems we've had historically is if you don't get a good seal at the just at the normal aorta, just below the renal arteries, what's a man to do, or a lady to do? Well, Aptus came out with their Helifix. This is essentially a device that goes up inside the graft, and it detaches a small screw which goes through the side of the graft and through the aorta and anchors the graft and basically staples the graft down to the aorta so that you get a good seal and you get rid of your leak of blood around the graft. And this is what it looks like in place. This is the Aptus device delivering the screw, and you can see a screw here, here, and here. So you basically put a ring of screws or nails around the top of the graft to anchor it in place and to seal it against the native aorta so you no longer have an endoleak. Now, does anybody have any chronic renal insufficiency patients? Come on, I'm sure somebody does. So what happens when they get an aneurysm, right? Do you give them contrast so you can do their aneurysm repair? Because they're certainly the healthiest patients in the room, right? So you want to do an open repair, not an endograft, right? Yeah, I know, it's getting tired. So what we can do in the patients, and Bart showed this a little bit, is if they've got chronic renal insufficiency, you can do most of their endograft using intravascular ultrasound. This is an over-the-wire technology. It goes inside the aorta. You can measure your vessels. So you can measure your target vessels here. You can measure your target vessels here. And this is what it looks like. Here's an external iliac artery. You know it's big enough to put your device through because you can measure it from the inside. You can measure the neck of the aorta. Here's the left renal artery. So that's your target point. You measure the size of the aorta so you can measure the size of your graft. Here's the aneurysm. Here's the IVUS catheter here in the middle. These are your common iliac arteries, so you can measure the size of your common iliac arteries. And you can see the takeoff of the internal iliac artery, so you know when your common iliac artery ends, so you know where to land your graft. And what it's been shown is that IVUS provides very dynamic imaging of aortic pathology and reduces contrast load and fluoroscopy time. You can be doing these cases with minimal to no contrast. So time and technology march on. I'm not convinced that I'm convinced at one point we're going to start seeing outpatient EVARs. I can tell you I did an aortic rupture on a 55-year-old guy a few years back. We did the aneurysm repair under local anesthesia at about 2 in the morning. And when I went back to see him around 9 or 10, he was walking around the ICU asking if he could go home. So that's almost an outpatient AAA repair. I felt guilty sending him home because he came in with a rupture. I kept him another day. I think that open aneurysm repairs are going to become increasingly rare because you get improved quality of life with AAA repairs and using an endograft technique, and morbidity is less important. All right, thank you.